It's yours.
Yeah, okay. Thank you. Uh, I'm sorry for the slight technical glitches. I think this is my financial interest. So I think I'll not be skipping this. I think so. What are the principles to correct presbyopia? Either you can do monovision, or you can go with the multifocality, or by create making the increased depth of focus. So these are the different options. I think you can tackle sclera by scleral implants with laser procedure. You can do cornea with a lot of corneal procedures available in the market. A lot of my friends still practices contact lens, of course. So gadgets of intraocular lens that really makes sound. So these so multifocal contact lens, I think is a non-surgical one. I think a lot of few of my friends are using a soft lenses from Bosch and Lamb, which is disposable. So these are the limitations with the contact lenses. Adaptation time required. It may reduce the contact sensitivity and also fitting. How to fit. So yesterday, one of our doctor was talking about. I think most of our friends been using this drop. This is from the meiotic agents. Basically, it's a parasympathetic drug. It induces the meiosis. It takes 15 minutes to act, and the duration will be around 6 to 8 hours. I think some of the doctors giving like a when and they require if the patient doesn't have the spectacle, carry these lenses in their pocket. Patient tend to put that, then they used to keep it there. This is how they practice us. Of course, a lot of my friends have been talking about this IOL based platform. I think multifocal beam we have been using for a quite long time. Again, I think there are a lot of advantages. Are there good range of vision without glasses? But definitely, all these ring lenses may have glare and halos. Trifocal lens, of course, definitely it has overcome with the multifocal because has got advantage of intermediate vision. Again, we have been doing. So advanced monofocal, I think we have been practicing with the similar kind of doing micro monovision in the non-dominant eye. Especially we started with the Rayner, especially the central optic. They created some positive spherical aberration in the lens. I think some cases of, especially if you do with the myopic classic, these lenses also sometimes really comes in hand if you want to do the micro monovision in the non-dominant eye. So quite a good lenses. Again, doing a knowing the spherical aberration in the cornea is very important for all these premium lenses. So of course he was talking about the Galaxy. Of course, the name is good. Again, some of the patients really do well. Again, depending upon their pupil size. If the pupil is mesopic, pupil size is small, I think these lenses also still do a very good job. Now, coming to few of my friends been using these lenses, Femtis EDOF lenses. I think this is a special optic lenses, especially when you combine with the femtocataract. So Rexis has to be perfect. This is a Rexis fixation IOLs. I don't know. In India, we do a lot of these lenses, femtis, but with very, very expensive. But the results are very good. It's aberration neutral lenses, and with it has got a smooth transmedial surface transition for maximum light transmission. So no rings, but it acts like a, something called a EDOF lenses, what Bosch and Lamb used to come, but the results are quite phenomenal with these lenses. Of course, these kind of EDOF lenses, when Zeiss launched this Lara, I think has been coming down because of still it has got a rings that will the patient may have a glare and halos. Sclerociliary complex modification. One of my friend, I think some of the doctors in Spain also doing this procedure by implanting a 4 pmms segments. What they say that sclera is supposed to be lifted to create more space between the ciliary space and the crystalline line that will have a near vision effect of around 1.5 diopter. Some of my friends from Taiwan still they do this procedure, laser rays procedure. What they do, they the around the visual light erbium YAG laser that ablate around 600 micron laser spots in the sclera, which are presumed to free again ciliary muscle from contact normally. Normally, will have a near vision of around 1.5 diopter. So Presby LASIK is the first started with which is a multifocal LASIK treatment, which is a biaspheric treatment. What they do actually, um, peripheral presbyl LASIK central zone is corrected for the far vision, and the peripheral myopic ring created for the near vision, which is better for the reversal. So, which is normally done with the Technolos 217 platform from NIDEC. Then coming to the central presby LASIK, of course, more physiological they started doing, more adaptation, stronger reading power, better for hyperopic. Then Presby Max comes from Squint. I think this is basically a biaspheric multifocal ablation. Still, a lot of my friends are doing, and the results are quite promising. Then in between EMO come with something called special lasers, especially for hyperopic. What they did, hyperopia presbyopia multifocal approach that steepens the central zone for near vision and leaves a periphery for distance. So hyperopic patients are really started doing well with the patient, not for the myopic patient. These are the few problems we could be able to do. Few of my friends, Ganesh and all, was doing this procedure with the presby LASIK adaptation problem, and it takes almost they'll have a blurred vision for 3 months with some amount of night vision problem. Then Bosch and Law again come with something called supracore. So what they do in supracore, they correct both the eye for distance and both the eye for near. But again, with the patient selection very important. Patient with the hyperopic, they started doing well. So basically, it's a very focal treatment, as I said, that they'll have a good distance, intermediate, and near vision. In between, again, Bosch and Lamb tried this something called intracore. Uh, they did something five intrastromal concentric ring cuts they had started doing, but again there are a lot of problems because it induces the negative spherical aberrations, so they'll have a near vision effect of around 1.5 diopters. Coming to the corneal inlays, few of our friends we started doing, we normally put this camera inlays in the non-dominant eye that increases the depth of focus similar to the pinhole, which is inserted in the stromal pocket, similar to how you do LASIK flap. These are the few corneal inlays which is available in the market. I think we don't use them that much. But these are the problems with inlays, slight reduction in the distance vision in the non-dominant eye, some amount of glare and halos, and a reduction in the contrast sensitivity. So, the Presbyon, this is the one treatment I've been doing from last 15 years. Uh, I've been very happy with this treatment. Basically, what we do, we make the dominant eye emmetropic, make the non-dominant eye myopic by 1 point diopters, and there is a blend zone where the vision from the both dominant and the non-dominant eye meets up. Along with that, we create a controlled spherical aberration in both the cornea. So by creating a controlled spherical aberration in the cornea, so the patient will never have a glare and loss. As I said that we make the dominant eye emmetropic, make uh, make the non-dominant eye myopic by 1.5 diopter, along with creating a controlled spherical aberration in both the corneas that gives us the blend zone, and there will not be any double vision or overlapping of the letters. So why we pick this micromonovision, more natural to the eye, as you seen in children with amblyopia, brain tend to suppress certain blur from one eye to the other eye. I need 5 minutes because it another. So this is about the technique, and so normally I spend with the patient, I take a lot of time, I ask the entire history, whether they're on any medications, whether they're on any of the allergy symptoms. Once it is done, I I look at the pupillary reaction, do the cover and make sure that patient doesn't have the squint, make sure that they're not having any glaucoma. Once it is done, I think the next very important step is to know the patient's dominant eye. This is very, very important. Lot of optometrists working with me, still I do the refraction, and once I do the refraction, make sure that the diochrome is balanced. Once it is done, I think uh, then I'll follow with the this is about the duochrome balance. Once it is duochrome balance, then I'll go with the how to check for the dominant eye. It's very simple. Make a small aperture in your both the hand. Make a small hole. Tell him to read for 636. Tell him to get the hand near to his eye. Normally, whatever the dominant eye, you tend to focus. Then you try to close each eye. Then whatever the eye when you are closing, then he starts reading. That means that is the dominant eye. The non-dominant eye has to be treated. Once you know which is the dominant eye for this particular patient, then you have to put plus 1.5 diopter to the non-dominant. This is called micromonovision testing. So once you are doing this, then tell the patient to read for N6, then tell him to read for distance with the same correction on in the non-dominant eye. Then if the patient start reading every letter, then no cross blurring, these are the patient do well. If the patient complaining of cross blur for 2 to 3 times, then don't pick them for this kind of treatment. Then once it is done, I think all other tests, I think similar to the LASIK test. So these are the different tests how you check for the dominant eye. Can you just go back to huh? Just 1 minute only.
Okay, 1 minute, please. 1 minute.
Yeah, one and a half minute. I'll try to skip. I'll try to skip as fast as possible. Once the data from the system, I think uh, it has to be transferred to the CRS master, which is the computer system given by the ZEISS. Then the whole procedure, the software has to be shifted to the machine. But this is the one test I do. I trace. I always look at the dysfunctional lens index. If DLI, in spite of all the tests, if DLI is low, don't pick them for laser blast procedure because the patient is not going to be very happy. Then once it's done, the procedure is as simple as that. How you do any of the, let's say first I do the flap with the Visumax, then take out. Once the treatment done with the Visumax, there is some amount of OBLs are there. Then still could able to lift the flap. Then the patient is shifted under the examer table. Then take to the examer table, then lift the flap, then go ahead with the lasers. I think as simple as that, how you're doing any of the lenses. So according to my friend Dan, I think more than 97% of the patient tolerate this treatment. Probably is a treatment not depend upon the pupil size. You can do wide range of power. So 97% of the patient adopt this treatment. So what is the best options? Okay, if the patient doesn't have cataract, you think about multifocal, trifocal, any of the lens-based procedure. Think about corneal rays. Think about presbyLASIK, supracore. As far as the distance vision, intermediate vision, near vision, night driving problem, pupil independent, adaptation, and reversibility, definitely presbyopia, lave, edge, or any of the treatment available in the market. I thank entire MIOM and my brother Mohammed Amri this opportunity. Thank you, one and all.
Thank you very much. We are run of time. I think we don't have time for question, but it's still many questions between your performance.
Yeah, one question
expectation.
come answer I'm going to tell. See, I've been doing last 15 years for this press beyond. Patients started coming, some of the patients started coming to me with the cataract. What to do? So we are putting it in an, both the eyes, non-aspheric monofocal lens and non-dominant eye, making them with a 1.5 diopter micromonovision. The effect of presbyound will remain afterwards also, even after the cataract treatment.
Yes.
Yeah, yeah.
Okay.
Thank you.